we're going to have somebody who needs no introduction come up.
This side.
Dr. Sujata Das is going to speak to us today about the outcomes of collagen cross-linking. As you know, she's from LV Prasad, and we look forward to hearing her thoughts on this.
Okay, thanks. Good morning. First of all, thanks to Clau for including me as a speaker in your session. So all of us know that corneal collagen cross-linking works. There's no doubt in that. But I'll go into the details, how it decreases, what are the different studies about the collagen cross-linking. So the basic, why we do it, because to strengthen the corneal tissue in ectatic cornea by inducing photochemically triggered cross-links between the collagen network using a combination of riboflavin and longer wavelength ultraviolet radiation. As all of us know, RCT are the most powerful studies to know any outcome of any new treatment. The first one was started in 2005-06 when I was a fellow in IBH Melbourne. So the first study says there's a significant difference if you use collagen cross-linking. So the settings were almost same as the other studies, but there's slight difference. The first one is the UV distance from corneal effects was 50 millimeter. Energy used, all three randomized studies were same. And but the third one is from UK. The exposure is 5 minutes in contrast to 15 minutes in the first one and 30 minutes in the second one. This is a surgery, I think people use various things. There is a lot of variation in the treatment with time. So the different parameters what normally studies focus is best spectacle corrected visual acuity, decrease in maximum simulated K, uncorrected visual acuity improvement, endothelial density, spherical equivalent, corneal pachymetry, any complication or corneal heads. I'll go one after another. So coming first to uncorrected visual acuity, the first RCT by Christine is for 36-month duration. They found significant difference between the cases and control. Whereas there is a significant improvement in cases, whereas the control has deterioration, so there is a significant difference. The second study here by Mayer is 60-month follow-up. This is 5-year follow-up. Again, there is a significant improvement. And control, there is no significant changes. But there is no significant difference between cases and control. And the third studies, even the cases are unchanged, the control are unchanged, there is no significant difference in 18 months. Coming to best spectacle corrected visual acuity. So there's significant difference from baseline in the first study, and again the second study there's no significant change from the best spectacle corrected visual acuity what we started and between the and what at the end of 60 months. Whereas the third study there is significant increase in visual acuity in both cases and control. So coming to Kmax. Kmax in 36 months it is flattened by 1.03 plus minus 0.1 diopter, whereas in control it has increased. So again there is a significant difference. And the second study again 5 years is a slightly longer term follow-up. The decrease is less compared to the first study. However, again there is a significant difference because the control has increased. Pachymetry. There's no significant, we don't expect the pachymetry to increase, rather there is a thinning in most of the studies, at least in the initial period there is thinning. The first study says the control has significant reduction, however the cases is static, so there is a significant difference. And the second study again after 5 months, again depends on which instrument you are using. The first one is ultrasound. We know ultrasound pachymetry may not be reliable in cases of especially keratoconus. In the second study there is a significant thinning from baseline both in case and control. However, there is a significant difference between the decrease in cases and control. And the third study after 6 months in off scan there is unchanged. Endothelial cell density, most of the studies have not noticed, but the first RCT by Christine they show that there is no significant difference in cases and control. I think if you know the pachymetry, you don't expect specular to decrease. There are various parameters seen by other studies also. This particular study has shown that a significant reduction in Kmax in topographic result. Uncorrected visual acuity has improved, whereas best spectacle corrected visual acuity has not improved. So corneal thickness, there is a significant reduction at 3 months, and endothelial cell density has not changed. So this study, again another RCT, the first group got the topography guided cross-linking, and the second group is normal routine cross-linking, and study duration is 12 months. So there's a topography guided, you can see significant difference in individualized topography guided cross-linking, and visual acuity, both uncorrected and best spectacle corrected, there is no difference. Similarly, IOP is not difference. Endothelial cell loss, there is no decrease in endothelial. Corneal haze has a, in the pulse cross-linking, there is a transient deterioration in vision at 1 month. This study is from Narayan Netralaya. They have divided into 4 groups. The first group is Dresden protocol, which is 30 minutes per 3 milliwatt per centimeter square, whereas the accelerated one per 10 minutes, again accelerated, they are divided into 3 groups, 10 minutes, 5 minutes and 3 minutes. So if you see steep K in 4 groups, the significant flattening in group 1, which is Dresden protocol, and corrected distance visual acuity. The group 3 has more improvement than in other groups, and thinnest Pachy, all of them has a significant reduction. The group 1 has a highest reduction. And specular count, I am surprised why specular count is a reduction in all these studies. However, there is no difference between the group, but there is a significant reduction in all the patients, all group patients. Demarcation line, this is well delineated between 1 and 2 and patchy in group 3 and 4. So complication, delayed epithelial healing in group 1 in 5% patient. In almost all except group 4, there is a delayed epithelial healing. Progression is seen in last 2 groups, which is per 3 minutes and 5 minutes. So another study which speaks about 3 long-term follow-up for 3 years. The outcome parameter they have taken uncorrected visual acuity, corrected distance visual acuity, corneal thickness, keratometry and endothelial cell density. There is no visually significant complication. For the topography, there is significant difference in baseline, but no significant difference between 3 years if you compare hypoosmolar and without hypoosmolar. So comparison of contact lens associated assisted transepithelial corneal cross-linking with standard epithelial op cross-linking for 24 months. This is a retrospective study. Patients were followed up minimum 24 months, and Dresden protocol was followed up. So contact lens associated was described by Sujan Jacob from Agarwal Eye Institute, and transepithelial CXL was used 0.25% riboflavin with 1.2% HPMC. If you compare both epi-op, contact lens associated, transepithelial, the maximum reduction in contact lens associated CXL group, however the results were comparative. Similarly, corrected distance visual acuity, it is better in significant improvement in epi-op CXL, and improvement was comparable again in all group. So efficacy in healing process, I think the most efficacy outcome should be efficacy in healing process. 6% eye progressed, whereas 94% regressed or stabilized in epithelial op. In contact lens assisted, there is no progression documented, and transepithelial also no progression. And complication, in transepithelial, 1 patient developed herpetic epithelial keratitis. So coming to complication in all these studies, the first study by Christine reported corneal edema with paracentral infiltrate in 1 case and subepithelial infiltrate. However, there is no adverse effect on best corrected visual acuity. The second study has Descemet fold and corneal edema and resolved in 10 days. We know sterile infiltrate is a complication and microbial keratitis, stromal haze, scarring, clear cornea with loss of, although the cornea was clear, the loss of corrected distance visual acuity, and recurrent corneal erosion also has been reported in corneal haze. So corneal haze after collagen cross-linking, it is normally, it is in the beginning of the follow-up, however it remains, it deteriorated with time. So in 1 month, the significant increase in corneal heads has been reported, and it remains elevated as compared to baseline at 1 year also, whereas in the transepithelial CXL, it returned to baseline after 1 year. To summarize, it has shown beneficial effect in progressive keratoconus by halting the progression of ectasia. It improves the uncorrected and best spectacle corrected visual acuity. It improves the corneal stiffness and better contact lens fitting. Like my previous speaker told that he always says that it may need contact lens. I always send the patient for contact lens trial before I do collagen cross-linking, because I know most of them will need contact lens trial. They should be aware that they need contact lens trial even if you collagen cross-linking. Corneal heads post cross-linking tend to decrease the visual acuity for short term. However, the long-term adverse effect is not mostly on the visual acuity. There are different methods of collagen cross-linking for thinner cornea or by reducing the treatment time have shown similar result. Thank you.
Thank you for the wonderful presentation. So, as you mentioned, there are different various methods for the corneal cross-linking. So my question is, in your hospital, do you have some kind of specific standard way to for this patient we choose this one, this method, or depend on the surgeons, or?
Mostly contact lens assisted we have never tried. We have tried only in the hypoosmolar if the cornea is thin. Nowadays we try to, if it is a thinner cornea, we ask the patient to close the eye when we put riboflavin. We have a study which is presented in a journal club that if you close the eye while putting riboflavin, the cornea does not shrink so much. So that is one change we have done recently for thinner cornea.